Hi, I'm Jim Demain. I'm a retired pulmonary critical care physician, and I've been getting a lot of questions about COVID-19 pneumonia, particularly in severe cases and in the elderly population. A lot of questions are about types of ventilation and what symptoms and signs of the pneumonia are. And there's been some publications as well, and I'll talk a little bit about those, but it's very early on to get data. By the way, this session is not on a beach in Hawaii somewhere with nice waves and palm trees. This is on Zoom with a virtual background, and which is certainly much nicer than my cramped apartment where we are in a stay-at-home mode. The COVID-19 pneumonia appeared to have started in Wuhan, China, as people know, and has spread now around the world. There's been quite an outbreak here in Seattle, and other cities are experiencing significant outbreaks, particularly in New York, but appears to be spreading. Today is April 1st, and it looks like things won't peak for another 2 to 3 weeks. And then hopefully what we're doing now with the preventive measures that we're taking, that things will be under better control. Also, rapid drug trials are being done because that's the main thing that will help. Vaccines are still about a year to year and a half away, probably more like a year and a half, although people are moving as fast as they possibly can. The COVID pneumonia in a small number of people can cause severe pneumonia. Most of the time, at least in 80% of the people, it behaves more like a cold. But in some, you'll get a sore throat, sometimes diarrhea, and fever, and cough. The shortness of breath becomes the disabling factor along with the cough. And of course, the disease is spread by what we call droplet nuclei, which spew out of the mouth, even with normal conversation, but even more so with a cough. It also can be picked up from surfaces, so washing hands and not touching the face is very important. But the pneumonia presents to a physician in an unusual way because it can progress rather rapidly and is a rather diffuse pneumonia causing a condition we call adult respiratory distress syndrome. On X-ray and CAT scans, there are diffuse abnormalities in a patchy area throughout the lung fields. This causes shortness of breath and oxygen desaturation. Normally, we can measure oxygen quite easily by putting a small clip on your finger, which measures your oxygen level on a percentage basis. And normally that's well above 90%. As pneumonia progresses, the oxygen levels drop well below 90%. And this means that the hemoglobin isn't able to carry enough oxygen out to the lung tissues. The lungs become so severely affected that they basically, you begin to fail. If you look at the lungs themselves as the membrane that transfers oxygen from air into the blood, if you took that as a single membrane and stretched it out, the surface area would be almost the size of a football field. So a lot of the lung has to be involved for the oxygen level to actually fall. So how do we treat that if you get into the hospital or get very ill? Well, the first thing, of course, would be oxygen. It can be easily given by nasal prongs, and the flow liters would be 2 to 4 liters or even higher per minute. And that, if the situation is mild, can correct the pneumonia while you're waiting for things to heal, or perhaps if you put on experimental drugs, which many of the sick patients had been tried on, that the disease might not progress and you might avoid more intervention. But when you become more short of breath and are having more trouble then you might be put in the intensive care unit, or prior to that, a trial of what we call non-invasive ventilation given. Non-invasive means without putting in an endotracheal tube. You're given a fairly tight-fitting face mask and a machine very similar to a CPAP machine, but it's called a BiPAP. Gives two levels of breathing. One pushes in on inspiration, and one holds the lungs a bit open on expiration. And it can be set with a timer to give you a certain number of time breaths if you're sedated and not breathing enough on your own. And sometimes with non-invasive ventilation, you'll begin to heal and avoid having to be moved into the intensive care unit and being intubated. But in a number of the sick patients, this scenario happens rather rapidly, and intubation is required. This is difficult for the healthcare workers because at this point, everybody has to be completely shielded and protected. So they have on basically hazmat suit and complete shielding of their face and eyes. So anyway, this can still be done. A family cannot be there. But if you need to be intubated, you're given sedation, and a tube is put down through your nose and or mouth into your airway, into the trachea. And then there's a cuff on the end of the tube, which can be inflated to prevent air from leaking. Then you're hooked up to what's called a ventilator. Now, what's a ventilator? It's basically, in simplistic terms, an air pump. It pushes air in and lets it out. But this is a very sophisticated machine costing close to $50,000 for the high-end machines. There are more simplified machines that can also be used. But this ventilator, you can dial in oxygen levels, you can dial in various pressures, you can adjust the pressures both on inspiration and expiration, vary the rate, you can do weaning trials, you can do suctioning. The variety of things can be done when you have the endotracheal tube placed that protects the environment, because there's a filter on the machine which keeps the exhaled air from circulating in the room, which could spread the virus without protection through a filter. So in the cases that have been reported, both in China and more recently in a New England Journal in Seattle, there's a fairly high mortality rate in senior citizens that end up being on a ventilator. In the China case that was series that was reported in the Lancet Journal, 10 people were over age 70, and 9 of them did not make it. In the Seattle series, it's kind of an early on report, but in all the cases they admitted to the ICU, half of them passed away, and the mortality rate in the seniors was about 62%, but some of them were still on the ventilator at the time that the paper was published. So it remains to be seen what the mortality is in the senior population. And some of that will depend on the amount of frailty the individual has and underlying diseases, such as diabetes, hypertension, kidney disease, and underlying heart or heart failure. So we have to ponder as seniors, I'm now 81, as if we did get a severe COVID-19 pneumonia, what would our options be? Well, some might want to try a trial of intubation, saying, intubate me, give me a good try for a week or two, but if I'm not going anywhere, if I'm not improving, please remove the tube and treat me with care for comfort. At this point, the palliative care team would move in, use drugs like morphine and sedatives, and help to manage the dying process. another decision you have to make if you do go under a trial like that, if your heart stops, would you want to have CPR? And a number of people in our age group at that point, I think, would elect not to have cardiopulmonary resuscitation, because if the lungs are failing and that causes the heart to fail, the outlook for CPR would be very minimal. You can also decide that I would not want intubation. That's called do not intubate. They would write DNI on your chart and DNR. In that situation, you'd give it your best shot with what we would call conservative treatment, which is supportive, with non-invasive ventilation, with trials of drug therapy. But a big problem that people are facing when they do go into the ICU, and this is true for both staff and for patients, is that the patient is isolated and cannot communicate with family. Now, iPads are being used, other tablets to have virtual communication with families, and that's good. And even documents can be signed, at least verbal permission given for various things. And I would imagine application program like DocuSign could be used, which does suffice for legal signatures. But it's a good time now to think about these things ahead of time. It's a time to update conversations with your family. I've mentioned two websites below on this video. One is Prepare for Your Care, which you can Google. It's a wonderful starting conversation, has all the forms, videos, and walks you through the needed conversation. Another is called the Conversation Project, which was started by Pulitzer Prize winner Ellen Goodman. And her mother had what she would describe as a bad death. So she has taken upon herself to gather experts and put together the Conversation Project, and this is well worth looking at. And Randy Curtis, who runs the Palliative Care Excellence program, Palliative Care Center for Excellence here at the University of Washington, has an article referenced there on having end-of-life conversations. This is something that I've been involved with in my retirement and off and on during my whole career, is talking to patients and families. And the time to do this is really when you're not in a critical situation. So please do have the important conversations. Consider what your values are, what your biggest hopes or fears are. Not only talk about them, you can write them down in an essay. Make sure that you fill out the appropriate advance directives. And it's very useful to have the POLST form that stands for Physician Orders for Life-Sustaining Treatment, the bright green form. Here at Skyline, everybody puts these forms in a hanging folder under their kitchen sink. And that's a very individual discussion that you need to have not only with your family, but with your medical provider, because your doctor, nurse, or PA, they signed that document, but you sign it. So it's a co-signed standing medical orders. And people that are in the medical field will adhere to that, and that document would follow you on the gurney if you're taken, for example, by Medic 1 to an emergency room. So I hope this video helps, and if you have any questions, please feel free to email me at jimdemain@comcast.net. Thank you, and please stay safe and stay well.